All right. Hello, everyone. My name is Ava-joye Burnett, and I am the moderator for this very special podcast series called A Journey for Women of Color, brought to you by Johns Hopkins Medicine, a woman's journey podcast, Insights That Matter. Now, as a news reporter, I know the importance of having vital, important, accurate information, especially when it comes to our health. And that is why I am here today. I thought it was so important for me to be a part of this. And so I hope you have had the opportunity to listen to the previous weeks of podcasts on triple negative breast cancer. That was a very important one. And also sickle cell anemia that affects so many people of color. And this week's podcast is the final in the series and focuses on diabetes and women of color. So my guest today is endocrinologist. Did I pronounce that right?
You did.
It's such a hard word. Dr. Sudipa Sarkar. Dr. Sarkar serves as the director of the Inpatient Diabetes Management Service at Johns Hopkins Bayview Medical Center in Baltimore. Thank you so much for joining us, Dr. Sarkar, and welcome.
Thank you so much.
So I know that doctors, you guys are steeped into the figures of all of the research that you do, but I just want to put some numbers out there for people who are not aware of how diabetes affects people, especially here in the US. So here are the numbers. According to the CDC, there's some facts that they've given out on their website about diabetes and prediabetes. So in recent years, the prevalence of diabetes has dramatically increased in the United States. Total, 37.3 million people have diabetes. That's 11% of the population here in the US. And what's even more concerning is some of these people don't know that they have diabetes. So the number of people who've been diagnosed is at 28.7 million people, including 28.5 million adults. So there are children in that. But here's a more concerning statistic. There are undiagnosed people here, and it's 8.5 million people. About 23% of adults are undiagnosed. And then when we talk about prediabetes, 38% of the adult US population has prediabetes. That's about 96 million people, 18 and older. They're pre-diabetic, and 65 years or older. Of these, nearly half of the population in that age group, about 26 million people, they have prediabetes. So that's a lot of numbers right there. And in the United States, Black adults are nearly twice as likely as white adults to have developed type 2 diabetes. There's a racial disparity there. I know we had a lot of figures, and that's why we are happy to have you, Dr. Sarkar, to break down this really, really complex topic. So let's start out by defining the characteristics of diabetes. We are type 1, type 2, type 3. Explain to us, what are the different characteristics of diabetes?
Yeah, thank you for that really excellent summary in terms of the statistics of diabetes that's really affecting Americans in the current day. So the way that I think about diabetes and the different types are that in people with type 1 diabetes, are unable to make insulin, or at the point where they will eventually be unable to make any insulin. Insulin is a hormone that's made by the pancreas, and it helps glucose from the blood go into the cells so that cells can make energy and so we can stay alive. So I think of glucose as a fuel source, and insulin is kind of like a key that allows the glucose to go into the body so it can be used to make energy. Without insulin, the body cannot use glucose. And so insulin is a really critical hormone. In people with type 1 diabetes, they don't make insulin, and so they do need insulin on a daily basis. People with type 2 diabetes, it's a bit more multifactorial, multiple elements that have an impact in the development of type 2 diabetes. In part, it is the person with type 2 diabetes, their bodies is having a hard time making enough insulin. On the other side, there's a second problem, which is insulin resistance, where the body is having a hard time responding to insulin. So it's really, it's a multifactorial. And then, besides type 1 and type 2 diabetes, there are other forms of diabetes, such as cystic fibrosis related diabetes, monogenic diabetes, the type 3C, which is a pancreas-related diabetes. But that's kind of the very basic way to explain different forms of diabetes.
Thank you for that. I didn't even know there was a type 3C. Today was my first time learning about that. So when we look at the different aspects of diabetes and prediabetes, let's start out with prediabetes first. What is that?
Yeah, it's a great question. It's thought of as a state in which someone who has prediabetes, we know, is at greater risk of developing diabetes. I mean, the kind of spectrum of normal glucose to diabetes is really kind of is really that. It's a spectrum. It's kind of a continuous line. And so, we do have cutoffs where we say, this person has diabetes, but that kind of state in which there's an increased risk of developing diabetes is called prediabetes. And those people may have higher than normal glucose, but not yet in the category we would say that, yes, this person has diabetes.
Okay. How do you know if you have prediabetes if you're not going to the doctor regularly?
Yeah, that's a really great question. So it does require a diagnosis, a lab diagnosis, but certain people may have risk factors for prediabetes, just as in with diabetes.
Mhm, mhm, mhm. Is it something that you can feel in your body?
Great question. No, and no, and that's a really excellent question. People can live with prediabetes or even diabetes sometimes for many years and not know that they have prediabetes or diabetes. So, seeing a healthcare provider on a regular basis is really the way to really know and kind of empower people to know whether they have diabetes or prediabetes.
Oh, wow. Thank you for that. It's good to know that you can't just feel it. You have to go to the doctor to get official diagnosis. So let's talk about diabetes itself. Is it hereditary?
It's a great question. Yes. It depends on the type, but oftentimes we do see in people with type 2 diabetes that it can run in families. So oftentimes, my patients will talk to me and say, "Oh, I have a parent with that prediabetes or type 2 diabetes, or have, a sibling with diabetes." So it does run in families. In type 1 diabetes also, there can be a familial component. So there can be there's a genetic basis as well.
And I guess I want to backtrack a little bit just from my understanding. There might be some overlap here of me just not understanding the terms, but I know of early or adult onset diabetes, and then I guess diabetes that you're born with. Which one is one and two?
Great question. Yeah, great question. So type 2 diabetes, I think traditionally many people thought of as, people develop when they're older. And that is true. Age can be a risk factor for type 2 diabetes, but the risk factors for type 2 diabetes have been changing over time. One of them is weight and body mass index. So over time, we know that the weight in the general population in the United States has been increasing over time, and that's been seen also in younger people and children and adolescents. And so, type 2 diabetes, although traditionally it was thought to be a disease of people as they get older, we are starting to see more and more often in children and adolescents. So type 2 diabetes can be seen in older people, can be seen in younger people.
Yeah, yeah.
Type 1 diabetes also has traditionally been thought of as, occurring only in childhood, but it can also occur in people in adulthood as well.
Okay, understood. So we're talking about diabetes in communities of color. So the lifestyle of Asians, Latinos, African Americans, it's so different. Even the diet, it's so different. So why is it that we're seeing diabetes being so prevalent among these groups, these people of color?
Yeah, that's a great question. I think that the risk factors that we just discussed earlier, excuse me one second,
Sure.
The risk factors that we discussed earlier. So definitely diabetes, type 2 diabetes can run in families. So there is a genetic component to type 2 diabetes. In addition, I think and other factors that affect a development of type 2 diabetes are diet and exercise. And in different groups of people may have different types of diet that's important to a person's culture or heritage. And so that may play a component. And then just access to food, access to healthcare. These may have an effect on when someone's diagnosed, and are they diagnosed when they have prediabetes? Are they diagnosed when they have diabetes? This certainly has an impact. So it's really multifactorial when it comes to type 2 diabetes, and why there may be like a disproportionate effect on people of color. And so really, I think we can look at it from, there's some unique genetic component and maybe some component from diet, access to care, access to food.
Oh, wow. So there's that social aspect to it.
Absolutely, yeah. And that's a really important part of diabetes care. And it's part of the standards of care really for diabetes, is to really address social factors that may play a role in someone's diabetes care. That has a huge impact, because we know that food, nutrition, exercise, activity, have a huge impact on diabetes treatment. And so, we can give a patient a prescription to, exercise 150 minutes a week, but if that person doesn't feel safe exercising at home, in their neighborhood, if a patient doesn't have access to, healthy foods because there's no grocery store nearby, or they don't have transportation, then we're not really getting to the root of the problem. And so I think, yeah, absolutely, like social factors have a huge impact on diabetes care. It's really like it's a very complex disease, and so many social factors have a role in how diabetes is treated.
One phrase that I learned from speaking with one of your colleagues, Dr. Sagunro, is modifiable factors.
Mm-hmm.
And that sounds like this is one of those cases where those are factors that are definitely attributable to this disease. But as a society, we need to be able to modify them. I want to talk to you about the diagnosis of diabetes. If someone goes to the doctor annually, they make blood tests. Is that how this is diagnosed?
Absolutely, yeah, it's a great question. So yes, it is based on blood tests. There's a few different ways to diagnose diabetes. One is based on fasting glucose that's drawn in the lab. There's another test called the hemoglobin A1C, and that test, the A1C is really not glucose itself, but it's an indirect measure of average glucose in the body over 3 months. So it's not like just a single point in time, but it's if you took the average of a person's blood glucose over 3 months, that gives you kind of an estimate of what that person's blood glucose has been over 3 months. So it doesn't give you like a day-to-day or even a range, but kind of gives you the average. That's one way to measure. Other measurements are if someone's had, elevated glucose in the setting of symptoms of high glucose, that can be a way to diagnose. And then there's another test called the oral glucose tolerance test, where a patient is given glucose by mouth to drink, and blood glucose is tested. So there are different ways to test. The A1C is very commonly used because of the ease of use. It doesn't require fasting. It doesn't require someone to drink something. And so that's very commonly used. And I always empower my patients to ask, like, what does that A1C mean? Like, where, is it good? Is it bad? Is it target? Is it the right A1C for me? What if I had to translate it to a blood sugar, what would it stand for? So, but those are kind of the different ways to measure and diagnose diabetes.
I'm curious about the A1C because I feel as if I've heard of it on commercials. So is that you draw blood and you could do it at home?
Great question. So it's a lab test. There are FDA approved kits where the A1C can be done at home, but generally it's done in a lab. The nice thing about diabetes clinics and some internal medicine clinics is that it can be done using what we call a point of care machine. So it's like just a finger stick blood sample, and then we get the result within minutes. So for me as a diabetes provider, it's really helpful, because if I see a patient that my patient gets the finger stick test for A1C, they come into clinic, I start talking, and then, I get the results. So that really helps inform the rest of the visit for me and helps my patient kind of understand what our goals are, depending on where the A1C is in relation to that person's goals and target.
This podcast is about health.
Yes.
So since we're talking about diabetes, what threat does diabetes pose to someone's health and their life expectancy?
Yeah, that's a great question. So diabetes has multiple effects on the body. And so, and that's something I also try to discuss with my patients, that it can have, untreated or poorly treated, can have negative effects on the eyes. So vision, so diabetic eye disease. So diabetes is a major cause of low vision. It can have effects on the kidney, so can cause damage to the kidney. It can cause damage to the nerves that supply, in the feet, for example. So if someone, has damage to the nerves to the feet, that can impair their feeling in the feet and could predispose them to injuries to the foot, developing foot wounds. And then also it is a risk factor for heart disease and stroke. And so all of these things I like to just review with my patients and make sure that we're kind of appropriately screening for any of these complications that can result from diabetes.
It just really sounds like a ripple effect. I was watching this segment last night on 60 Minutes, and they talked about someone's ability to be able to get a limb, prosthetic limb after amputation for whatever reason. And one thing that really got me was the fact that people were able to feel the nerves in their feet, and then they were able to balance and walk better. And I think of those things like the sense of touch. So, and you talking to me about the nerve damage, it makes me think about the ripple effects and other lifestyle things that we come to take for granted sometimes. Oh, wow. Okay, so I want to talk to you about different types of treatment. The great folks at Hopkins sent over some like a guide for me for this podcast. And one thing that was in there was metformin. Did I pronounce that correctly?
Good, excellent. Yeah, great.
What is that?
Yeah, it's a great question. Metformin's been around for a long time, over 50 years. It's a medication taken by mouth. And it's relatively inexpensive. It can be gotten for $4 a month. And so, it's been around for a long time, relatively inexpensive. It's taken by mouth, can be taken once or twice a day. And basically it helps improve the body's sensitivity, the way the body responds to insulin, and it decreases the glucose that's made by the liver, because that's one thing that we see in people with type 2 diabetes, is that there's more glucose that's made by the liver that goes into the bloodstream, and so it kind of lowers that. So I really like metformin because it's inexpensive. It's a medicine that's taken by mouth, and it really doesn't cause hypoglycemia or low glucose. So it's a good medicine for all those reasons. It's also weight neutral. So many medications in general, some medications can cause weight gain, but metformin doesn't. It's considered a weight neutral medicine.
I think people would like to hear that, especially people who are having to use this. So is type 2 diabetes managed exclusively by this drug then, or are there other types?
That's a great question. So it is one of many types of medications that can be used for people with type 2 diabetes. In the past, I would say 20 years, like the number of medications for diabetes treatment have really expanded, but metformin is one of many tools that we have to help treat type 2 diabetes. That being said, the kind of foundation of the pyramid of treatment for type 2 diabetes is really lifestyle, so diet and exercise changes. And then on top of that, we think about medications, and metformin is one of them.
So I'm curious about side effects with regards to metformin. What are the side effects? I read there could be stomach discomfort. And
yes, that's a great question. Yeah, so some people may experience stomach upset, loose stool, stomach upset. Generally, it's temporary. So I always warn my patients, like it may last for a few days and it tends to go away. But I generally, as a result, because of that, I'll start at a low dose and see if my patients can tolerate it, and then we increase it over time. But yeah, the stomach upset can occur in some patients. If patients don't tolerate one form of metformin, there is an extended release form that many people do tolerate if they don't tolerate the immediate release. But yeah, absolutely right. So the stomach upset is really the big adverse effect that we counsel patients about. The metformin dose is adjusted based on kidney function. So that's another thing that I look at kidney function, and we may need to adjust the dose of metformin based on kidney function. Very rarely, there's something called lactic acidosis, buildup of lactic acid in cases where there's hypoperfusion. So, but that's exceedingly rare. And I generally tell my patients, look, if you're not eating and drinking, just don't take metformin then. But it should be taken when someone's eating and drinking normally.
If someone's not diabetic, they may not understand the treatment and how often people get these forms of medication. So is it one a day, once a month?
Good question. Yeah, so the metformin is taken generally once or twice a day by mouth.
Okay, so these side effects could kind of be a nuisance while helping to manage a very serious disease. That's an issue.
Yeah, and I think that's why the patient-provider discussion is so important. Just being, just explaining, potential side effects and kind of counseling patients. This may happen. It's most likely going to be temporary. If not, just making sure that they contact our office and let us know if they're not able to tolerate the medicine.
Okay, so I'm going to go into a series of questions that have to do with something that has been in the news lately.
Yeah.
Ozempic. We hear about that all the time.
Yeah.
But before I go to that, I just wonder, are there any newer forms of treatment, like alternatives to metformin?
Yeah, there's a whole lot of different medications for type 2 diabetes, and actually the Ozempic or semaglutide is one of them. So that's a newer class of medication that's been approved for the treatment of type 2 diabetes.
Mm-hmm. And you said newer. I feel like Ozempic is all over the news right now just because of alternative forms of usage. But how new is Ozempic?
Yeah, Ozempic's been around for a few years, and the way it works, so Ozempic is the brand name. In the generic form is called semaglutide. So Ozempic, that form of semaglutide, is approved for use in people with type 2 diabetes. And it is it's a weekly injection. So it's a weekly subcutaneous under the skin injection. And the way it works is it works on different organ systems, but we know it works on the central nervous system to decrease appetite, so people don't feel as hungry. It helps people make insulin in response to food. Excuse me. And I'm sorry, my light keeps going off in my office. And it kind of slows down motility of the GI tract. So people feel full because there's, like the GI tract is kind of moving more slowly. And so not only does Ozempic or semaglutide taken once weekly as an injection help improve glucose, it also helps with weight loss because of its appetite suppressing effects.
Understood. So how is type 1 or insulin dependent diabetes managed? Is it managed through something like Ozempic?
Great question. So, type 1 diabetes is really the main factor is that patients with type 1 diabetes cannot make insulin. So the treatment for type 1 diabetes is insulin.
Oh, I see.
Yeah.
I guess I'm kind of going back and forth and it's to understand the difference here.
Yeah.
So then let's talk about this whole issue of Ozempic. And the reason why it's been in the news is because people who don't necessarily or have not been diagnosed with diabetes, they're using this to help with weight loss. There are issues with that because the people who really need it have been running into problems with getting that drug. Should people who do not have diabetes be using this for alternative alternative reasons of losing weight?
Such a great question. So Ozempic, as that brand name, is only approved by the FDA for type 2 diabetes. So, without a diagnosis of type 2 diabetes, Ozempic, it's only approved for type 2 diabetes. That being said, there is a form of the drug semaglutide, and there's a separate brand name called Wegovy. It's the same medicine, but it's a different name and different doses. And that is approved for weight loss in people with obesity or people with overweight state and comorbidities. So Wegovy semaglutide is approved for weight loss in people with elevated body mass index. Ozempic is approved for type 2 diabetes.
Are you finding that some of your patients were having difficulty in getting this drug, Ozempic, because others were using it? So many more people were in such high demand.
We know that it's been a national shortage of the drug. And so recently that's improved a bit, but my patients were struggling to find the medicine. So we were, we had to figure out alternatives or find a pharmacy that carried it. And so it's been challenging. We're starting to see it kind of ease a bit in recent weeks.
How was that affecting your patients who needed this drug to literally try to stay alive?
It's been difficult for patients, to have a medicine that's really helped their blood sugar, help their overall diabetes care, and not have access to it. It's been very challenging. And so we've been really working hard with our patients to find supplies of the Ozempic where we can, talking with the company that manufactures the drug and talking to the representatives saying, hey, we need help. We need help getting this medication to our patients. And so it's been kind of a multidisciplinary effort, from patients, from our group of providers, from our staff in clinic, and working with the company trying to find supplies. And I think we're starting to see the light at the end of the tunnel. We're starting to see it improve a bit, but it has been challenging.
Yeah, thank you for helping us understand more about that.
Yeah.
Well, you mentioned the pancreas and the important role that it plays in preventing diabetes or moderating insulin within the body. So how about this really interesting concept of pancreas transplants? Can you tell us about that?
Yeah, it's so that is a treatment, but it's in a very select groups of patients with diabetes. Many times we see it it's done with, for example, a kidney transplant. So someone who has type 1 diabetes also has end-stage renal disease who may be a candidate for a transplant of both the kidney and the pancreas. And then there's certain patients with diabetes who may have such serious complications with insulin therapy that they may be considered a candidate for pancreas transplant. But yeah, it's really indicated for very specific populations of patients.
Okay. Is there any research that is underway that may influence the presence and the course of this disease?
Yeah, there's currently research ongoing, clinical trials that are in phase 1 to 3, looking at different medications for type 1, type 2 diabetes. One medication that was recently approved last year that we're using is called tirzepatide. The brand name is called Mounjaro. That works very similarly to semaglutide or Ozempic. Tirzepatide is an agonist, so it's a medicine that binds to receptors in the body, and it works very similarly to Ozempic in its effect on appetite suppression, helping with increasing insulin response to food, and also lowering weight, which many patients with type 2 diabetes are trying to decrease weight because their weight may be higher than their goal.
Yes. So you are running right into my next question. You don't have diabetes. What should you do to ensure that you're not going to get diabetes with regards to your weight?
Yeah.
And even if you know that you have a risk factor within your family, what should you be doing at this point?
Yeah, I think really making sure that I would counsel that person to have just to speak with their healthcare provider and kind of going over what are the unique risk factors for developing diabetes. Is it a strong family history? Is it kind of activity, not having enough physical activity, or is it diet, maybe not having access to healthy foods? In what parts, I think, Ava-joye, as you mentioned, like what are modifiable, like what is modifiable for that person? And then kind of determining, does a blood test need to be done? How often does a blood test need to be done to kind of keep an eye on developing diabetes in the future? But those are kind of the main things, looking at, what are a person's unique risk factors from, being part of a family, from the family, genetic risk factors, and what are, diet and nutrition and activity factors that could be potentially modified.
So let's break that down,
Yeah.
starting with the activity. If
Mhm.
someone is overweight or their BMI is a little bit elevated,
Yeah.
if they lose weight, can this legitimately become a preventative measure for them to not get this disease?
Yeah, we know that weight loss is definitely a way to help prevent progression to diabetes in people with prediabetes. Absolutely. Yeah, exactly.
And then we talk about nutrition, that is huge.
Yeah.
So help us understand the carbohydrates, the role that plays.
Mhm,
I don't know,
mhm.
fruits and natural sugars and
Yeah,
fruits play a role,
yeah,
or um, ice cream, for example. I love ice cream.
yeah.
What are the different types of food and the different subsets that have a contributing factor
Mhm.
to developing or exacerbating
Yeah.
diabetes?
It's a great question. So it really has to be tailored to the person. But you're right, in people with diabetes, we do focus on carbohydrates, and it's really individualized to the person. But looking at carbohydrates, because that can, in people with diabetes, cause an increase in blood glucose. So, for any of my patients who have diabetes, I make sure that they have a diabetes self-management training and education visit with a diabetes educator, where nutrition is reviewed and kind of goals for carbohydrate in the diet that's reviewed. One major thing I tell my patients, or I kind of counsel them, is to avoid sugar sweetened beverages, so beverages with sugar added, because that's a way that oftentimes people don't realize that they're getting a lot of sugar in their drink. And so if that's something that can be cut back or eliminated entirely, that can have a really big effect on blood glucose. So yeah, carbohydrates, that goal should be discussed with a nutritionist or diabetes educator. And then just in general, I would recommend to my patients kind of trying to cut back or avoiding beverages with sugar added to them. You mentioned fruit. Fruit can have carbohydrates, but carbohydrates are not bad. It's just kind of being mindful of like the number of carbohydrates that a person's eating if they have diabetes.
Yeah, you just have to strike that balance. And because we're all so unique and our bodies are so unique, that's why you have to talk to your doctor.
Yeah, absolutely. Yeah.
Wow. Whew, thank you. Thank you for that. So I want to talk to you about resources then, because
Yeah.
this is such a complex topic.
Mhm.
Are there websites that people could go to, apps that they could use to just help educate themselves?
Yeah, absolutely. So the American Diabetes Association has a lot of great resources on their website that are very patient friendly. They have a great section where they go through like recipes for people with diabetes that kind of have kind of like the number of carbohydrates and calories and nutrition facts, which is really great. So there's different types of like dinner, breakfast ideas, dessert ideas. So that's really helpful. One app, there's so many apps out there. So there's the apps that I'm suggesting are by no means like the only apps, but MyFitnessPal is an app that I'll recommend sometimes patients use to get a sense of like what the nutrition and carbohydrate content is in their food, just a way to log it. And then one of my colleagues, Dr. Rita Kalyani, has a website called the Johns Hopkins Patient Guide to Diabetes, and that has some great recipes and has some great resources for people with diabetes.
Is that what you call the macros of your diet?
Oh, yeah, macros, yeah, like the macronutrients, the carbohydrates, fats,
Yeah.
proteins. Yeah, yeah.
And so that's where an app like MyFitnessPal would be really beneficial
Mhm.
because
Yeah.
if you're not a nutritionist, you don't know these
Yeah,
things.
it's hard to know exactly. And then there's another resource, Calorie King. It has an app, but there's also like for patients who are not into apps or prefer to have out like a book or something in print. There's a little tiny book called The Calorie King, and really it has like calorie and carbohydrate nutrition information about really any type of food. So it's
Mhm.
really convenient and it's small enough that it could be carried in a pocketbook. So
Oh, that's pretty awesome.
yeah.
Like we can all become experts at what we are consuming.
Yeah, yeah. And the other thing is I encourage my patients to look at nutrition labels if they get a box of cereal or they have like a loaf of bread, look at the nutrition labels in the on their food, and then also looking at serving size. So that's another point to be really careful about is what's considered a serving size. Is it 2 pieces of bread or 3 pieces of bread or just 1 piece of bread? And the nutrition facts should say like this is the number of carbohydrates per serving size. So it's really important to kind of understand what the serving size is for that food.
Yeah, there's oftentimes that shock factor when you see the actual serving size and you're
Yeah,
like, wait a minute, I actually want 2 slices of pizza and they're
sure.
telling me it should be 1/4 of a slice.
Yeah.
I wonder if once someone gets diabetes, is there a reversal where they will no longer have diabetes, or is this a lifelong disease?
Yeah, I counsel my patients. It is kind of a chronic progressive disease, but with lifestyle measures and medication, patients can control it. So I think that's the nice thing about diabetes care is that certain parts of it are modifiable and treatable, and that it can be controlled, which is really reassuring.
That's good. That's very good. If you could stress just one single thing to
Mhm.
women of color with regards to diabetes,
Yeah.
your one main takeaway, what would that be?
Yeah, I think to have kind of a really frank discussion with healthcare provider and kind of reviewing any potential concerns about personal risk factors, be they family history of diabetes or diet or activity, and say, am I at risk of diabetes? And if so, what can I do to prevent it? And do I have diabetes? And if so, how do I know if my blood glucose is at target? How often does my blood glucose need to be monitored? And what's the right treatment for me? And what are side effects and what are benefits from different medications?
So just talking to that medical
Yeah.
professional. Oh, yay, Dr. Sudipa Sarkar. Thank you so much. I just want to make sure that there isn't a topic or something that you wanted to mention that I didn't ask.
No, I really appreciate this. Has been a great range of topics that are, I think, so important for patients to hear.
Yeah, thank you so much for your time today. We really appreciate it. And I know everyone who will be listening, oh, they're going to love it too. This is good stuff. Thank you.
Thank you.
And everyone, thank you for joining us today for this special podcast on diabetes for women of color. It has been my honor to serve as a special guest moderator for Journey for Women of Color. Thank you, Dr. Sarkar, for being our guest for today. This activity is supported by an unrestricted contribution from Lily. If you've enjoyed today's discussion, please check out A Woman's Journey's website, hopkinsmedicine.org/A Woman's Journey, for information about upcoming free webinars. Subscribe to A Woman's Journey's Insights That Matter podcast and sign up for A Woman's Journey's monthly email. And I said, if you've enjoyed it, I'm pretty sure you have because I really enjoyed today's podcast. Thank you, Dr. Sarkar.
Thank you so much.